as a lot of you know, you get tested for sleep apnea. You get screened for it, and then if you screen positive, then you have a home sleep test, and if you're positive on that, then you have become acquainted with a CPAP or a BiPAP. And so a lot of people wonder what happens after they've had surgery. And so we have Dr. Eveloff today, who is a sleep medicine physician, and he's going to talk to you today about after surgery and about using your CPAP, and just answer any questions you have about sleep apnea. So, Dr. Eveloff?
Well, don't hesitate to interrupt if any questions come up.
Is that turned on? You don't sound very loud. Let me see, are we still on mute? No? It should be. Oh. Oh, there we go.
Okay.
It's working now.
There you go. So as I was saying, don't hesitate to interrupt if anyone has any questions out there. There are probably very few, if any, bariatric centers who don't have some connection to sleep. You may wonder, when you're first enrolled in the program, why do you even need a sleep study? Why is there someone like me connected to the sleep disorder center? So I'm going to just give you a little overview of how sleep relates to your particular population, what sleep apnea is, and what you can expect. And like I said, feel free to ask me any questions you want. Sleep apnea is incredibly common. Even among non-overweight and non-obese people, it's very common. Sleep apnea is very simple to define. It's where the airway actually closes down at night during sleep. When this happens, oxygen isn't getting to the lungs, your oxygen drops, that kind of wakes the brain up out of sleep just enough to open up the airway and get you breathing or snoring again. It's not really where you stop breathing, like a lot of people say. You keep breathing, you just can't breathe against the straw that your airway has become, and so your oxygen will drop. That's sleep apnea. It's incredibly important in the general population because if it happens enough, you can feel sleepy or tired during the day, which is the main symptom of sleep apnea. But even more importantly, it's been shown now that significant sleep apnea can worsen or predispose to high blood pressure, can worsen or predispose to development of diabetes, can worsen or predispose to development of heart disease, including coronary artery disease, predispose you to a heart attack, predispose you to arrhythmias like atrial fibrillation, and it can worsen or predispose a risk of stroke. So it's not just a matter of feeling sleepy. It can really damage your health should you have undiagnosed sleep apnea. It can actually affect all sorts of other things that can lead to headaches. It can lead to getting up to going to the bathroom a lot at night. I've had several urologists who refer me patients with a presumed big prostate, and they wound up having sleep apnea. And you cure their sleep apnea, and they don't get up to go to the bathroom at night. It can knock the whole body for a loop. So it's incredibly important to diagnose and treat in the general population as well as in your population. And the reason your population is so important is because the main risk factor, not the only one, but the main risk factor for having sleep apnea is overweight or obesity. When you get up to the morbid obese range, probably 50% or more people will have sleep apnea, regardless of anything else. So, and again, the population that presents here, it's incredibly common. And so, that's one reason that you want to look into it, is because there is already a very high index of suspicion for you having it if you're in need of bariatric surgery for being overweight or obese. But there's other reasons for a center like this to look for sleep apnea people, and really to put everybody through at least a home study. Sleep apnea, if it's identified, is a qualifying indication for bariatric surgery. In other words, it is a disease that can possibly be corrected once you undergo bariatric surgery and lose weight. But even more importantly, in terms of my opinion, is it's a risk, depending on how severe the sleep apnea is, it's a risk factor for anesthetic and surgical complications. Not just for weight loss surgery, but for any surgery. Anytime you get anesthesia, if you have sleep apnea, that puts you a little bit of risk of having complications, such as low oxygen, having difficulty waking up, having your airway closed down after surgery, or having them unable to put you to sleep easily. And the more severe the sleep apnea is, the more serious this risk factor is. So that, in my opinion, is the main reason for people, again, undergoing any type of surgery, but especially for people who already have an elevated risk of sleep apnea, to be evaluated for it before they're put to sleep for bariatric surgery. And there are some studies I read where the risk is exceedingly high. It's rarely a cause to cancel a surgery, especially because anesthesiologists these days are very well tuned to sleep apnea. Any anesthesiologist you see, if you tell them you have sleep apnea, well, you should tell them you have sleep apnea. And if you tell them you have sleep apnea, they will take appropriate precautions. Still not 100%, but as I said, it's become a huge, huge preoperative risk factor for anesthesiologists to be aware of. So that's really why pretty much everyone who gets evaluated for bariatric surgery has to at least have some assessment for sleep apnea. Ideally these days is a portable home study. You want to identify sleep apnea in a population where you probably have it. You want to know that it can be corrected with weight loss, and you want to let the anesthesiologist know what they're facing when they put you to sleep. Those are the main reasons why populations such as this need to undergo sleep studies. Okay. And again, once you have it done, once you start losing weight, I guess one question that arises is going to be, well, can it resolve with weight loss? And the answer is yes, but not all the time. As I said, obesity or being overweight is the main risk factor for sleep apnea, but it's not the only one. There are overweight people who don't have sleep apnea. It's not, not everyone who's overweight or even obese will have sleep apnea. So there's something else going on that has to be factored in. And that something else is the fact that in people with sleep apnea, there's some misconnection between the brain and the muscles of the pharynx, where the message to stay open isn't there anymore. And that's why thin people can easily have sleep apnea. And you can't get rid of that. There's no way we have of treating that misconnection between the breathing center of the brain and the pharyngeal muscles, so that, if you lose weight, yeah, the majority of people, I think, will improve or possibly even resolve their sleep apnea. But that's not 100%, and that shouldn't be 100%. There are people who will continue to have sleep apnea even after weight loss. It's going to improve, but again, there are people who will have sleep apnea. I know in my practice, though, I've been continuously astounded by the people who get the weight loss surgery, come in, they've lost weight, and they don't have sleep apnea. That can definitely happen, and that's what makes being in a bariatric center or even being a sleep physician so gratifying. Sleep apnea isn't necessarily permanent, and the main way to treat it, short of a CPAP machine, is with weight loss. So, and that's why most people who go through the surgery will have a post-operative sleep study when they've, I guess, plateaued at a reasonable enough weight loss to see what the status of their sleep apnea is. And even if it's not completely treated, it still doesn't mean you need CPAP. And that's kind of a misconception. Some people will just get labeled with sleep apnea. Well, there's mild, moderate, and severe sleep apnea. Sometimes mild sleep apnea may be there by the numbers, but you still may not necessarily need to have it specifically treated with CPAP, and that's a judgment call. But I've seen a lot of people who get carried on with CPAP when they may not necessarily need it. So I would say that the overall message is very hopeful. for people with sleep apnea and weight loss. There's a good chance you're going to resolve your sleep apnea. There's an even better chance that it's going to improve. And there's a reasonable chance that you may improve enough to where you may not need a CPAP machine. Okay, so, but again, there are other factors associated with sleep apnea besides being just overweight. It's a major factor, but it's not the only one. Other factors, by the way, that enter into it: nasal congestion is a big risk, is a contributing risk factor for sleep apnea. So if you have sleep apnea, you've lost weight, you still have a little bit of sleep apnea left. If you do have chronic nasal congestion, be it allergies or polyps, that's certainly something to look into. Various medications can also contribute to sleep apnea. Typically, these are sedative medications or pain medicines, which is, again, another reason why anybody with sleep apnea, anyone undergoing surgery needs to be evaluated for sleep apnea, because after surgery, most people are put on pain medicines, which can worsen your sleep apnea. So it's not just the getting into surgery, it's the coming out of surgery and the post-operative recovery period that is also important, because things change. You're on pain medicines, you may be on sedating medicines, you've got to be very careful in the post-operative period as well. And then finally, a lot of people with sleep apnea actually get put on sleeping medicines or sleeping pills because they tell their doctor, I wake up a lot at night, or I can't sleep, or I'm tired during the day, and sometimes the reaction is to try and deepen sleep with a sleeping pill, which is quite honestly the absolute wrong thing to do, because sleeping pills can worsen sleep apnea as well, which is why some people who get put on a sleeping pill and they come back and say it's not working, or maybe I feel worse. Well, maybe you feel worse because the sleeping pill is making your sleep apnea worse. So again, there's all these subtleties of people who are predisposed to sleep apnea, who get treated for it either the right way or the wrong way, and who are going to undergo surgery. Any questions so far?
In your opinion, is the only way to really treat that successfully is with a CPAP machine, or you see these other things, you can insert things into your mouth, and there's a ton of stuff out there?
There is a lot of stuff out there, and I turn on the radio and probably every other commercial is about something for sleep apnea. My answer is, again, yes, but, okay? CPAP pretty much works across the board, mild, moderate, severe, because it pressurizes the whole airway. It doesn't matter where the airway is closing down. Yeah, these other options like mouthpieces, yeah, sure, I'm a big believer in them, but you have to pre-select the patient. Mouthpieces tend to work better in people with mild to moderate sleep apnea, and they actually tend to work better in people who aren't significantly overweight. So mouthpieces can work, but just going to one of these dentists and getting a mouthpiece, you got to be very careful, and be very careful getting them off the internet, where the Zipa device, ZYPPAH, it can work, but now you're not only dealing with the subtleties of patient selection, but you're purchasing a mouthpiece that's not adjustable, just a kind of a one-size-fits-all, which it really doesn't. So, you know, yes, if you want to ask your doctor about a mouthpiece, it's reasonable, but they shouldn't just refer you to a dentist, or they should refer you to a dentist who's going to evaluate you more, okay? So, like I said, CPAP works across the board. Mouthpieces are okay if it's done with a bit of intelligence, okay? There's this other device called the Inspire, which is also heavily advertised, which is pretty revolutionary, actually. What it is, they implant a little pacemaker right under your skin here, like a heart pacemaker, but instead of the wire going to your heart, they tunnel the wire up to a nerve that controls your tongue. And so every time you breathe in when you're asleep, it stimulates this nerve, and the tongue actually moves forward, so it opens up the airway. And again, it works, but you really have to be pre-selected for an Inspire device. That's good for people with moderate to severe sleep apnea who don't weigh an excessive amount, and I forget what the actual cutoff is, but can't weigh too little, you can't weigh too much, and then you have to undergo a special endoscopy to make sure that your airway opens and closes in a way that the device is going to work. So again, all these other things can work, but they require a lot of sort of pre-selection first.
Can you talk a little bit about the mechanics of the throat and why obesity is such a risk factor, and then how that changes with weight loss?
The reason human beings have sleep apnea at all is because through evolution, we've been enabled to use these muscles here for all sorts of things. We sing, we talk, we swallow, we breathe. And so unlike a lot of animals or mammals out there who don't have a lot of talking ability, our pharynx has been developed to enable us to, like I said, talk, sing, swallow, breathe, all with the same set of muscles. Because of that, they're very collapsible, okay? And so whenever any of us go to sleep, all of us, our muscles relax a little bit. Our airway always narrows when we go to sleep, again, because it's collapsible. What sleep apnea, or what obesity does, or being overweight does, it essentially adds more of a load to these already collapsible muscles. Not only a load up here, but also here, and for a variety of reasons. The more weight you carry here, the more collapsible your airway is. So it's weight here, kind of pushing people predisposed over the edge to having it. Okay, so that's why I'm saying it's not the only risk factor, it just is the straw that breaks a camel's back, in other words. Okay. But yeah, unfortunately, we're all predisposed to sleep apnea, and that's why actually everyone's entitled to a little bit of sleep apnea during sleep. We don't define it as sleep apnea by the definition unless someone stops breathing more than 5 times per hour. So, I mean, everyone's entitled to a little bit of sleep apnea. Everyone's oxygen drops a little bit when they sleep. It's just that obesity will magnify the risk of sleep apnea, and obesity actually will magnify the amount of droppage of oxygen at night. So even if obesity doesn't predispose to sleep apnea, it can independently disrupt breathing and oxygen at night, even without leading to airway closure. So it's a big risk factor for a lot of things associated with breathing and sleep, obesity is. And that's why you will definitely improve substantially as part of your sleep with weight loss alone.
I have a question about events per hour. I kind of understand how that was before I had my CPAP. Now I have my CPAP and I get a number of events per hour. Are those related at all to each other?
Yes. What your machine does is it's supposed to tell you how much sleep apnea you're still having despite wearing your machine. There's a lot of uncertainties about that. First of all, the machine you probably have is an auto-PAP machine. Now, there's CPAP, which stands for continuous positive airway pressure. And that's because you dial in the pressure and it expands your throat to that pressure, 8, 10, 12 centimeters. Auto-PAP, you don't dial in the pressure, you tell the machine a low pressure and a high pressure, and the machine is supposed to sense when your airway opens and closes and raises it and lowers it accordingly. Well, there's automatically going to be a little bit of sleep apnea there for the machine to even react to. So that's the first bit of uncertainty, is anyone on an auto-PAP machine is probably never going to achieve 0 events per hour, all right? The second point is, the way the machine judges that is it looks at the airflow pattern coming in and out of your throat. It's a little unreliable, so I always take that number with a grain of salt. Yes, it's supposed to correlate to the number that you had on your sleep study, but it really doesn't, all right? I look for either pretty low numbers, 5 or less, or pretty high numbers, I don't know, 10 or more. And even that I take with a grain of salt. So you should always monitor it, okay? But you should use it as a guide, not as an absolute, all right? So yes, it correlates roughly to what you had on your baseline study. If you stop breathing 50 times an hour on the initial study and your machine shows 5, 6, as far as I'm concerned, that's great. Okay.
So what are the signs then that you, quote, no longer need a CPAP, that would tell you, hey, it's time to retest?
And if someone came to me and asked me that, I'd say, well, what happens when you don't wear your CPAP? And I would say, well, I always wear my CPAP. So I will tell them, stop using the CPAP and just see if a bed partner still hears snoring, see if a bed partner still sees or hears you stop breathing, see if you're waking up a lot, see how you feel during the day. You know, we use those clinical clues first just to see, but the bottom line is, you know, I always tell people if they lose only 20% of their body weight, at least contact me. It doesn't mean I'll automatically refer them for a sleep study, but 20% of body weight to me is pretty appreciable. And then the more you lose, the more chance there is of getting better. So, I mean, there is no absolute. First, you just see, you know, what's going on at night and during the day, if that's changed. If that's changed, I would definitely go and get reevaluated. Even if it hasn't changed, doesn't always mean everything. Eventually, you will need to get reevaluated.
I get those advertisements for that machine that cleans your CPAP. How
Right.
effective are
The
they?
So Clean machine.
Yeah.
Costs about $250 or $300. I think their leads are, their advertisements are extremely misleading, okay? In my experience, no one has ever died of a dirty CPAP machine, okay? Unless you keep your CPAP machine in a hog barn or a swamp somewhere, it's not going to accumulate life-threatening bacteria or viruses like they show on TV, which is not going to do it. Now, that's not to say you shouldn't keep your own machine clean,
Right.
but I'm of the opinion that if you keep your machine clean, you wash it with soap suds and water weekly, maybe vinegar and water monthly, you don't need the So Clean machine. It'll work. Well, it'll work, but you don't need it. Plus the fact that So Clean doesn't clean off the oils and everything else that accumulates. It just cleans off the bacteria. So that's my opinion about the So Clean machine. Okay. Yeah.
Does snoring always associate with sleep apnea?
Absolutely not. No. And that's why, I mean, when people come to me with snoring, that's the whole issue. Is it snoring? It's just snoring, in which case it's more bothersome to the bed partner than to the patient who's snoring, or is it snoring and sleep apnea, in which case it becomes a medical disorder. So, and that's where, you know, you ask all these clues. Well, do you stop breathing? Are you sleepy? Are you overweight? Do you have an enlarged neck circumference? That's what I do with anyone who comes to me for just snoring, is you want to tease out who has an increased risk of sleep apnea out of those, and then study those people. It's a little different in kids, by the way. Kids, snoring always has to be taken seriously, but adults, no. Just because you snore doesn't mean you have sleep apnea. I think you have a question?
Which mask is best?
Well-
Which mask is best?
There is no best mask. It's entirely personal preference. I always try and start people off with at least something over the nose or under the nose. For some reason, a lot of durable medical equipment companies out there like full face masks over the nose and the mouth. That's a lot of mask, number one. Number two, they tend to leak more than a nasal mask. So unless you have horrendous nasal congestion or you're an obligate mouth breather, I would say at least try and start off with either an under the nose device or an over the nose device first. But it is personal preference. There is no right or wrong mask device.
Okay. I'm only getting like 50% of the usage of my CPAP machine. So I'm trying to use it in compliance, but it doesn't seem to be.
So then I would come back to you and say, well, why? What are you feeling? Why are you not using it 50%? Is it, I
I
mean,
get congested in the nose.
okay. What kind of mask do you have?
I have the under the nose.
Under the nose? There's a lot of reasons for people to get nasal congestion on CPAP or AutoPAP. And, you know, there's a few ways to treat it. So, like I said, if you would come to me, I would say, all right, let's look and see what we can do about clearing up your nose first. Maybe you need to change, maybe even just to an over-the-nose mask. Worst case scenario, you know, a full face mask. But the bottom line is, you shouldn't get put on CPAP or AutoPAP and just be left to your own devices. A lot of people like you don't accommodate or don't initially accommodate. Well, it's a work in progress. And so that's why you need to be with someone who, you know, will listen to your complaints and and try and act on your complaints. Some people never achieve adequate compliance, but in those people, you want to make sure you've done everything you can first, whether it's clearing up the nose or trying different masks or even trying different pressures. So again, I would say you're not alone. You just need to be sort of guided through, what can be changed. Yeah.
I have a reverse question of the other one. If you have sleep apnea, do you always snore?
It's a good question. Typically. There are some people who don't. That's pretty unusual, but you can. Yeah, well, you can. But typically snoring is the main thing that brings someone to presentation.
When I first got my sleep apnea machine, I got it because number one, I was falling asleep during the middle of the day, and I knew I was tired. And then my wife told me, "You're gasping for air in the middle of the night." So
Okay.
then I got it. That was over 15 years ago. Well, after I lost my weight, I never went back for a sleep study. And she's been on me. She goes, "Well, you ought to go back and get a sleep study." And I'm like, "Why? I'm fine. You said I don't snore. I'm not gasping for air anymore. I feel good." I've just been, no reason, I didn't think I need to do it. Do you think I should? Or
Was your sleep apnea severe, do you know?
I don't think so. I mean, if you look at the level of, I was pretty low on the, whatever a 4 or 7 is, 7 out of what, on the scale of, on the sleep apnea machine. I don't know if that means anything.
Oh, you mean your pressure was low?
Pressure was low.
That doesn't
Okay.
mean anything.
Then I don't know the answer to that, whether I was severe or not.
Okay. Honestly, when you get a test, not you, but whenever anyone gets a medical test, find out what it shows, because, you need to know, you need to be your best advocate, okay? But
I might have known 15 years ago, but since then, I don't know.
Okay. Yes, my answer to you is yes, because you can still have sleep apnea with just very minimal snoring. And you don't want to let it go because, silent sleep apnea, in other words, sleep apnea that's sort of asymptomatic, can still be a risk factor for high blood pressure, stroke, etc. So I would say if you've had sleep apnea, yeah, you deserve a reevaluation. That can be done as something as easily and as cheaply with a home study, automatically to go into a sleep lab. But yeah, I would say anyone who's been diagnosed with sleep apnea, who's undergone a clinical change, yeah, you should have reevaluation and just know for sure.
And how do home studies work?
In terms of,
Well, compared to when you go in to get,
okay, well, so most of you probably have undergone home studies. There's a lot of different home studies out there, by the way. The ones I like and the ones that are used here evaluate airflow with a little airflow monitor on your nose, evaluate respiratory effort with a little band either around your chest or your chest and belly, and an oxygen monitor on your finger. So it looks at just the nuts and bolts of sleep apnea: airflow, breathing effort, and oxygen. Now, some of them have snoring mics, and some of them have a few other things. But that's the bottom line of a home study, and they're really very simple. Again, it's one band here, or maybe 2 bands. All right, thing on your nose, thing on your finger. Plug it all into a little monitor, and it records it overnight. That's a home study. Okay, an in-lab study monitors about 14 different levels of physiologic function. You have your brain wave, your airflow monitor, your heart monitor, your breathing monitors, your leg monitors. I mean, you're really pretty much wired for sound. There's some reason to do that as opposed to a home study. There's some reason to do a home study as opposed to an in-lab. But for the purposes of this population here, where you're at a high risk of having it because of your weight, maybe you're snoring, or you're witness to not breathe, home studies really are going to give you the information you need, assuming everything stays on at night. Okay. Yeah.
Could you still have sleep apnea even if you're sleeping through the night since surgery?
Absolutely. I mean, I get a lot of people in here who don't, and I get a lot of people in my office who don't think they have sleep apnea because they don't wake up a lot. See, when your oxygen drops, it may not wake you up to full consciousness, but on the brain waves we use in the sleep lab, we're always seeing the brain kind of pop up out of sleep. So yeah, you may think you sleep the whole night through or wake up once or twice, go to the bathroom. You could still be having severe sleep apnea. So that, yeah, you could definitely still have sleep apnea even if you're not demonstrating sleep disruption.
I have a silly question. My husband does not snore, but he puffs. Is there, I mean, it's just all night long.
I've had people bring in recordings of their bed partners to convince me that they have sleep
I have
apnea.
recorded this.
Okay. And I always listen to it, okay? But the noise someone makes is just a real rough estimate. It's the tip of the iceberg. I can't say if puffing is a risk factor as opposed to snoring. I can't. And again, that's why I would add in all the other things that may go along with sleep apnea. Awakenings, going to the bathroom at night, daytime sleepiness, presence of high blood pressure. It's no one thing. You have to combine all these things. So being overweight, I mean, you know, if he's thin, a marathon runner, and he puffs at night, I say, oh, probably not sleep apnea. But again, the sound someone makes is just one piece of the puzzle. It's the best I would have to tell you. Yeah.
Could you tell us what a clear airway apnea is? What that means?
Oh, is this on your machine?
Yeah.
Yeah. That stands for it's pretty complicated. It's okay. When you have sleep apnea, as I said, your airway closes down. That's an obstructed event or an obstructive event. If you just stop breathing, but you don't close your airway down, that's a clear airway event, and it's clear because it means that your airway is open, but for some reason you just stop breathing, then start, then stop again. That's called central sleep apnea, which is just a whole different animal, and I would be very cautious getting that from your machine. As I said, under the best of circumstances, what you read on a download from your machine has to be taken with a grain of salt. Then when the machine starts to differentiate an obstructive event versus a clear or a central event, it could be right, but I wouldn't hang your hat on that. But that's what it means by a clear event. It means an event where you don't close your airway down, you literally just stop breathing and start again. And that's much more rare than obstructive sleep apnea.
Is that more dangerous?
No, it's not more dangerous, although typically central sleep apnea, if it's significant, there's some reason for that. I mean, with obstructive sleep apnea, the reason, I guess, might be obesity. But for central sleep apnea, either you're going to sleep on top of Mount Everest, I mean, that's part of altitude sickness, or it's a risk factor, it's a sign of maybe heart disease or neurologic disease. And these days, actually, the major risk factor for it are opioids. We've all heard of the opioid, epidemic. High potency opioids can predispose to central sleep apnea. And if someone is on opioids, I might take that clear airway thing very seriously then. So, those are some of the risk factors for central sleep apnea. Yeah.
Can you explain the importance of enough sleep and losing weight?
Of what?
Having enough sleep and
Oh.
aiding losing weight?
You mean, okay, yeah, there's definitely a correlation between just amount of sleep and weight. Now, we're not talking sleep apnea, just amount of sleep, yeah. It's been shown that getting insufficient sleep, which depending on what you look at is 5 hours of sleep per night or less, maybe 6 hours of sleep per night or less, it can alter your hormone levels, and it can elevate the level of a hormone that increases appetite. And so, yeah, there is some evidence to show that just getting insufficient sleep can predispose to weight gain, no doubt about it. How much, I don't know, but the amount of sleep you get, it can tie into either your weight gain or your ability to lose weight. So getting enough sleep, as well as making sure the sleep you're getting is good, is important. It is. I said, I think y'all are really doing the right thing. I think there's every reason to think that whatever sleep disorder you have or sleep malfunction you have can certainly improve with what you're doing. I'm happy to answer any other questions someone may have laterwards. But good luck to you all.
Thank you.
Thank you.